Welcome to CPR Cycles. Expand your CPR knowledge and the time it takes to do one cycle of BLS. This is episode 2, Epinephrine, the good, the bad, and the ugly. Catecholamines are probably the most studied drugs during CPR. We know that with excellent basic life support, we only get about 30% of a normal cardiac output, and that means that the core organs are going to be ischemic because they're only getting about 30% of their normal blood flow. Catecholamines cause peripheral vasoconstriction through stimulation of alpha-1 receptors, and that will redirect blood flow to the core to improve that core perfusion. The catecholamines that we use most commonly during CPR, namely epinephrine, also have beta effects. And so the question is, are those positive or negatives? It was initially posited that those beta effects were actually the major positive effect of a catecholamine. And that's because we know that they increase coronary and cerebral blood flow by increasing inotropy and chronotropy. But they also have been shown to have detrimental effects, things like increases in myocardial oxygen consumption, increases in ventricular arrhythmias, decreases in hypoxic pulmonary vasoconstriction, and also impaired microcirculation. And so on average, there are these positives and negatives to the catecholamines that we have to consider when we're giving something like epinephrine to a patient. Now we have to think about the question of high-dose versus low-dose epinephrine. We know that the administration of high-dose epinephrine is associated with an increase in the rate of return of spontaneous circulation, at least in human clinical trials. So you see this forest plot here, and overall, looking at these human clinical trials, we've got a beneficial effect in terms of return of spontaneous circulation. Patients more likely to achieve return of spontaneous circulation with high-dose epinephrine than with low-dose. But unfortunately, if we look at that same data and then look at survival to discharge, you can see that overall we have a decrease in survival to discharge in these patients who receive high-dose epinephrine. And so that's a big problem if we're thinking about giving this drug. We may get that short-term effect of a return of spontaneous circulation, but if the patients don't survive to discharge, are we really achieving anything useful? And these possible mechanisms of why this survival to discharge is lower sort of relate back to a lot of those beta-1 effects that we talked about. And so those beta-1 effects, when we have a lot of epinephrine around, may actually be pretty detrimental to these patients, at least in the post-cardiac arrest period. So what do we know from clinical studies in epinephrine? There was a meta-analysis published back in 2015 looking at survival to discharge in patients receiving epinephrine compared to a placebo group. And you can see there was a statistically significant improvement, over 2 times as likely for these patients to survive to discharge if they received epinephrine. But when they looked at neurologic outcome, there was an increased rate in poor neurologic outcome in the patients who received epinephrine. And the question at that point was, do we see increases in poor neurologic outcome because more patients are surviving, including those who had more brain ischemia, or is there something else going on here? That led to the Paramedic 2 trial, which was a prospective placebo-controlled randomized trial looking at epinephrine versus no epinephrine. And here you can see survival to 30 days significantly improved in the epinephrine group, between 1.4 and 1.5 times as likely to survive to 30 days. And then when we look at favorable neurologic outcome at 3 months, there was no difference between the two groups in terms of their likelihood to have favorable neurologic outcomes. You can see that the confidence intervals cross 1 in this study. That means that there's no statistically significant improvement. But in general, looking at the trend, if there is a trend here, it's actually favoring the use of epinephrine. So this trial really suggested that likely epinephrine is useful in these patients. What do we know about when we should give epinephrine for non-shockable rhythms? This is data from another human study, and the important thing to note here is this is the time when epinephrine was given, and the black line here is the percent who survived, and you can see that the longer they waited to give the epinephrine, the less likely patients were to survive. Now, this is observational data. It's not the same as a prospective trial, but it does suggest that early epinephrine is probably a good idea for non-shockable arrest rhythms. Okay, so what do the recovery guidelines say about epinephrine? First, we do recommend the use of low-dose epinephrine every 3 to 5 minutes as early as possible in CPR for the non-shockable arrest rhythms. That would be pulseless electrical activity and asystole. You can consider the use of low-dose epinephrine for prolonged shockable arrest rhythms. So that means after you've gone for at least 10 minutes of a shockable rhythm and at least 5 defibrillation attempts before we would think about low-dose epinephrine because of the potential that it may worsen that arrhythmia. And then finally, you can consider, again, just consider high-dose epinephrine with prolonged CPR of greater than 10 minutes, but only as a Hail Mary in patients you're about to give up on. So this is only for patients where you truly think there's a minimal chance you're going to get them back. Because again, remember that the use of high-dose epinephrine is associated with a worse incidence of survival to discharge. So just to summarize, epinephrine is useful during CPR, especially for the non-shockable rhythms. You can give it every 3 to 5 minutes at a low dose. And then for the shockable rhythms, only after 5 defibrillation attempts or 10 minutes of that shockable rhythm. And remember that it may worsen those shockable rhythms. We recommend high-dose epinephrine very, very rarely, only with prolonged CPR where we are about to give up, not for patients that you think have a chance of coming back. Remember, it's the Hail Mary. It's the pass from all the way down the field to the end zone, which is very unlikely to be successful. So we're only pulling this out if we think we're very unlikely to be successful. So those are the basics of epinephrine in CPR. Thank you for joining us for this episode of CPR Cycles. If you'd like to learn more about CPR, please visit our website at recoverinitiative.org. There you can learn more about our standardized online training. It's the only veterinary CPR training that was developed by the team who wrote the guidelines, is endorsed by the Veterinary Emergency and Critical Care Society, and offers CPR certification through the American College of Veterinary Emergency and Critical Care. With Recover CPR training, you can feel more confident, competent, and connected in your CPR attempts.